traveling, and 3D printing. As a member of esteemed professional organizations such as the Canadian Retina Society, AAO, Canadian Ophthalmic Society, Association for Research in Vision and Ophthalmology, Dr. Youssef remains committed to staying at the forefront of ophthalmic innovation and delivering the highest level of care to his patients. That was a mouthful. Thank you so much for being with us. It's a funny time to ask people to speak on a Friday evening, so we really appreciate it.
Thank you. Thank you for inviting me. Thank you. So are you guys ready?
Yes.
Okay, let's take it away. Okay, let's see here. Can you see the screen? Can you see the full screen?
We see you.
Yeah. So the whole full screen, you can see it? Okay. So my talk today is about immediate sequential bilateral cataract surgeries. So this is the newest name for this procedure, was bilateral cataract surgery. So let's get started here. So first of all, we want to talk what is ISBCS, okay, and why would we do it, and how would we streamline it so it becomes safe and effective. So traditionally, we call it delayed bilateral sequential. So it's traditionally we do one eye and wait days, weeks, or months, typically a few weeks, and then do the second one, which is called delayed sequential bilateral cataract surgery. So what we're talking here about is we are talking immediately sequential bilateral cataract surgery, which involves, so we do one eye, change everything as if a new patient is coming in, and we do the second eye immediately after in the same surgical visit, but with completely new setup. So there's a global shift in the incidence of the bilateral surgeries. So from a paper from 2016, this was the sum. So in Finland, is about 50% of the patients are done bilaterally in 1996. And Spain is even more than that, is 80% of all cataracts are done bilaterally. In Canada, we are far, far lagging behind. In 2003, it was 1%, and 2009 is 2.3%. This is when I started doing bilateral surgeries at that time. And the reason is simple, apart from the fear of having bilateral complications, the surgeons are penalized for doing bilateral surgery. So this is how it's done. So Japan, the surgeon is not reimbursed at all for the second eye. So the second eye is a bonus. In Australia, they receive 50% of the first eye payment. In Canada, it's about, in Ontario specifically, it's 85%. It varies from a province to province. And in UK, about 80% of the first eye. So this kind of penalizing system for the surgeons make the surgeons think, why should I do it? You know, it's a loss of income. I see it as differently because I compensate for that decrease in pay with increased efficiency. So for me, I do it for the community and do it for the whole system. So I've been performing that routinely since 2009. Everybody does some of these occasionally. So especially for patients under general anesthesia, they usually do bilateral procedure for those. But to do it routinely is the difference here, to be routine. So we started from 2009, done over 6,000 of these procedures, almost 13,000 eyes as bilateral procedures. And thank God we have zero bilateral infections. So occasionally can get a complication, but not related to be bilateral. So why would you do bilateral procedures? It's full of advantages, actually. So if you look, it's mostly from the patient's convenience and patient side. It's a safety and efficiency for the patient side. So the patients enhance convenience. They go by once, improve quality of life and psychological benefits. Anxiety is much less that way, and reduce exposure to risk. And we realized this in COVID era. And from the healthcare point of view, it's a much more efficient of healthcare's resources, and it's cost effective. So enhance patient's convenience. So a patient goes one time to the hospital, they go back and forth multiple times, rather you can just go one visit, and you should go to the visits at the office one time for both eyes. and we do actually now do the same day follow-up. So we see the patients the same day, especially convenient for patient coming from out of town. So they come do the surgery, you have the follow-up of the first day, and you have the 1 week follow-up either at the office or later at their local optometrist. So this way, it's much more convenient for the patient. The recovery time is much faster. So for example, I had to cancel a day next week. So the patient that had done single eyes last week, they're going to be rescheduled for a month later. So it delays the recovery of those patients. I'm trying to squeeze them in to try to compensate them for this delay. But see, this overall recovery, it gets delayed by a few weeks to months, especially, for example, before COVID. Few patients can ask to have done a single eye. So did one eye before COVID, and then COVID hit. So the second eye got delayed months later because of that kind of delay. So this delayed recovery can be extensive. Usually it's about 2 weeks for the delayed sequential. It's immediately sequential, but it's delayed much more if something happens, if somebody gets sick and stuff like that. So it delays the recovery extensively. So with that, it improves the quality of life. The patients can be rehabilitated really quickly. The vision is equal in both eyes. Significantly, they can start doing their own things really quick. Even patients living alone can do their own affairs. They can, within 2 hours, they can start using their eyes. There's no patching, and usually they can drive in 24 hours. So surgery has changed dramatically from the old days. That's why we're able to do both at the same time. Patients that live alone have usually concerns about this. They think they're going to be patched. They can't see nothing. So this doesn't happen. And psychologically, so the anxiety waiting for the second eye, usually the patient build up a lot of anxiety, especially if their experience at the first eye wasn't that good. So having both eyes done at the same time delays or reduces or cancels that kind of anxiety for the second eye operation. So, and it immediately gives them a chance to adapt and be happy with their vision and move along. So exposure to risk, we realized that in COVID because now the healthcare system started to encourage people to do bilaterals. And that's what saved our hospitals from having humongous waiting lists during that period, because we were able to do the much more surgeries with the least number of patients doing it bilaterally. So, and it's the use of the resources. So, a patient coming for one eye or both eyes, there's a lot of procedures that are done equally for either one eye or two eyes. So, the day surgery procedures, all of them, doesn't matter if you're coming one or two eyes. So, it's better use of the nurse resources and hospital resources that way. And it reduces the burden on the healthcare system. That's why our waiting list in our hospital is much shorter than other hospitals, because we can do bilaterals, can do much more in a day. Of course, this all adds up to the economic and cost effectiveness of the bilateral surgeries, because it's for everyone. It saves money, including patients, family, hospital, healthcare system. The only one that's penalized in this is the surgeons, but if the surgeons realize they can compensate for the loss of income by increased efficiency, they realize that it still should be done. I've been doing that for 15 years now. The direct and indirect costs. So every time we do a bilateral procedure that way, we save the community as a whole $2,500 per patient. Usually the worry is bilateral complications. It's very rare. The way we do things, we standardize things, we don't cut corners. It's made this surgery much safer. So TAS, for example, is extremely rare nowadays because we have strict protocols for sterilization and the supplies and everything. We don't have those kind of things anymore. It's really very rare. So one of the things that we also a challenge with having bilateral surgery is not being able to use and fine tune the results of one eye to fine tune the second eye, and especially that is important for post-refractive procedures. So refractive procedure, when they do corneal refractive procedure, they change the shape of the cornea. So the calculation of lens implant power gets much less accurate. So we usually do those post-refractive procedures in one eye at a time and wait 2-3 weeks in between and read the results of the first one and then fine-tune the results of the second one. But this actually became also tackled by, we have that now what's called light adjustable lenses. So the light adjustable lenses is a big advantage now for the post-refractive patients to find to be able to adjust it. So for these patients, we calculate the lenses and we implant the lenses, and we can actually adjust their lens power after the surgery by exposing it to certain kind of UV light. The UV light will get the lens to reshape, so we can add power, decrease power, remove astigmatism, correct astigmatism that way. It's a pretty marvelous lens, and these lenses have been there's a paradigm shift in my practice with those lenses, because with these lenses I can actually achieve better than 20/20 vision, because I can fine tune the smallest amount of errors of refractions, either astigmatism or spheres. So the light adjustment is very simple actually. After the procedure, about 3 weeks after the procedure, we calculate how much adjustment do we do, and we expose the lens to the UV light with this computer system, and it modifies the lens power. It's amazing. So, of course, I've been doing it for 15 years, so I streamlined the procedure and made it much more efficient and time effective. So I think this video is not working within the presentation, so I'm gonna work out to this one. Okay, so this is how we do the procedure in the hospital. So I move the patient myself always. It gives me a chance to give them instructions and give the nurses a chance to set up and do their things. So I hate to sit around. So that's what I do. Move back and forth the patient, give me instruction before the surgery, instruction after the surgery, and give the patient that personal touch, which is very, very effective to decrease the anxiety. So once I bring the patient in, this was the first patient of the day. So I do some stuff that's very specific for the first patient. I always tape the patient's head. I don't want the movements during the surgery, and I try to do things one time, and that's it. I'm cleaning up the skin of around the eye, and I also mark the floor for the first patient, so that we don't keep moving the foot switches around and try to guess where they should be. I use the Avogard, which is a very quick antiseptic, and so it saves time. Every second counts in this procedure. Up there's this is Oxyflex, so I don't put a mask on the patients, so we don't have this consumable that you need to throw away in between patients. So this, let me just go back a tiny bit here. So this is a tube that brings oxygen through that coming from the anesthesia machine. So it brings oxygen underneath the drape. I made an extension for it. This is from the dollar store. It's a phone holder, so it extends the holding of that to have the drapes elevated. So I don't have to have this tinting of the drape using another device. So I tried to decrease the amount of devices we use during the procedure, and decrease the consumable and landfills. This is a user. I pass the wires here, so you don't need to keep adjusting it during the procedure. Now we see we're starting always on the right side. The nurses know that we always start on the right side. Now Bonnie set up the table for the right side, and she's not done yet, but we have enough stuff to start the surgery. So we started the surgery while she's not done yet. She's still calibrating the machines and everything. And once she's done this, she will move to the left eye tray to start to set that up. So she left here. She set me up enough to start the surgery, and now she's working on the left eye table, so that once we are done, the switch is really quicker. That way, there's no wasted minute. Everybody knows what they're doing. It's like choreographs. It's very well organized. Everybody knows what they're doing, and we work here as a team. It's the team is the one that makes this work. So I'm doing the phaco. I'm going to talk about the steps of the cataract surgery in the second eye of that patient. Once we're done, we're talking about the streamlining of the bilateral procedures. So Bonnie's finishing the setup on the left eye table. She's going to come back to to help me out to finish up the procedure. She took the lens. And one of the most critical, I can stop here for a second. One of the most critical things that can cause errors is the having switching the right and left eye lenses. So I don't check the lenses until I'm actually sitting on the patient and make sure that I review I confirm that I'm doing the right eye of the patient so and so, and then review the lens measurements and lens power of that eye. And so this is a kind of a second pause. So we do the first pause during this setup, but the second pause, which I do it at this stage, it's very crucial to do that, because one of the theoretical mistakes that you can do is to switch right and left eye. So at lens powers, and of course they can be different. So that's why I stopped here. So now we're finishing the right eye procedure. Bonnie, when she was setting up this table, she never touched anything that I touched the patient with. So there's no cross contamination from one eye to the other. You cannot touch. If you touch anything, you have to stay here. Don't go to the second table. So I have to be very, very strict with anything related to infection. Infection here, we should have zero chance of infections. Now we're done with the right eye. So we're tearing down this table. Everybody knows this is doing this really quickly. You can see it's like NASCAR. It's kind of switch. So and now we're getting ready for the left eye. Left eye table is already set up, almost complete. So I marked the floor in that eye too again, and go sterilize and where the things. I don't like anybody to pass me any instruments, because it's a waste of time and risk of dropping the instruments and injuring each other. So I'm going to set up the left eye surgery. Okay. And at that time, we don't check the lens until I'm actually ready to start the surgery, not starting the surgery yet. So we pause here. Where's my mouse? So we pause here. We wait until I make sure I say which eye is it. Everybody's listening, and we review the lens power with the lens star measurements and expiry date. And I read also the white wide diameter and the central cornea thickness, which is important for the design of the wound and cuts itself to optimize things during the surgery. Let's keep on. So we're starting the surgery on the left side. Maybe I'll talk about the steps of the left side procedure now that we know how is the switching. So we can do a 2-point, let me just close down here. Okay, so we open a 2.75 incision and fill the chamber with the viscoelastic, do the rhexis. I measure the rhexis so that it can be reproducible all the time. Do hydrodissection, hydrodelineation, nuclear rotation, which is dividing the layers of the cataract. So I do the chopping technique, which is one of the most efficient ways to remove the nucleus. So cutting down the lens into fragments, quadrants, and remove them quadrant by quadrant. And then the epinucleus, and I use J cannula for cortical cleanup rather than IA at this stage. So the J cannula goes in and irrigates the content of the capsule out. So you can see the capsule was cleaned really quick. This is the heel on, then implant the lens and do IA. And I use the lens at that time as a shield to protect and avoid having a complication of posterior capsule tear. I inject, I hydrate wounds with the antibiotics, so because it's very important to avoid infections. And I inject the dropless injection, which is a mix of multiple medications to avoid infection and inflammation. And with this way, the patient does not need to put medicated drops. They can still use the lubricant if needed. Okay, we're done with the surgery. I take the patient myself, and I talk to them about the post-operative instructions. And once they leave the hospital, they go for the follow-ups. So I'll bring the second patient in a second, and now we can see the tables are being set up again. So we ended up in the left side. So we start the second procedure on the left side. That's how I arrange all my day that way, so I know how to arrange it. So, because some patients, if it's a difficult surgery, I would start with the easier eye. Okay. So Now, this is how we do things in the center. Of course, in the center, I have a little bit more control so I can modify things. And I'm going to start talking about this room here. So if you see, this is Jordan here. Hey, Jordan. Such a sassy standing, right? Okay. So this is the, see the room in the back there? This is a glass room. It's completely separate from the main room with separate ventilation. So this is where we prepare the extra tables. So in between the patients, the two tables for the next bilateral is already set up in that room. So whenever, so for example, Sue comes early, she prepares 4 tables. So 2 tables for the patient that coming and 2 tables for the patient, the next patient. And once we're done with this patient, we'll move the tables out and bring the 2 patients, the 2 tables in. This way we can produce much more cataracts in shorter period of time that way. So let's play. Doesn't want to play. Let's see, move this here. Okay. So patient came in, and we start always with the right eye. The same thing, same exact thing. So we start the right eye. The 2 tables are ready already. Review the lens again. Pause, and we have to review it, make sure it's the right lens. And I check the corneal thickness. It's important for the wound angulation. So you can I ask that what's important with the corneal thickness. So if the cornea is too thin, you're gonna angle the wound more, so that produces a longer wound. If the cornea is too thick, we angle the wound less. So this way you end up with at least 2 millimeters of corneal depth of the wound. And this is important because you want to avoid infection. So we're done the first eye. So we switch around. This chair is very convenient. It has a platform that we have the foot switches on, so we can easily move from one side to the other. So it's much more convenient that way. It's a fancy thing. While checking the lens, you can see on the right side. Check the lens, make sure everything is good. We're going for it. So this is the left eye now, and everything's set up ready. Usually takes about 5 minutes each procedure, so it's really quick. And once we're done with this one, patients move out, and the new tables will come in, and this already set up and complete. And the eye that we ended up on, for example, the left eye, will be the first eye of the next patient because everything is already set up in that time. So we took it out, put the new drapes on, the new tables are out, and ready for the next patient. The patient's already set up. This time lapse is real. I didn't cut anything out of it, so it's a real time lapse of what's happening. Same thing here. Review the lens. This is the synergy. The first one is the eye hands. It's synergy. So now the Troy went in with the new with two other trays, and he started to set up the 2 trays for the patient number 3. So this way, it's once he's done. Once Jordan has time, actually, she can go in and set up the tables further. So you can see we're finishing up this. Troy was already ready on the other table. So once we're done, he's already set up for that side. Jordan went into the room and started to set up those tables. It sounds confusing and complicated, but it's very, very simple. It just makes sense. So we're doing the second eye of this patient while Jordan is setting up the the 2 tables for the third patient. While we finish up this, the lens is implanted, IA is done. And we're done with that patient, so we can move out, clean up the drapes, put the 2 new tables in, and third patient comes in. So we ended up in the left eye. So we're going to start on the left eye. Okay, so third patient is in. Ended with right side, sorry, and now it's starting on the right side. And already Jordan was in the glass room, came out to the glass room, and she's already set up with the tables, ready to rock and roll. So that way we save a ton of time. Time down between the patients is all negligible. So So this way, in the hospital, we can easily do 45 cataracts a day. Now we currently do 32 cataracts a day, and we can go much more than that if they listen to me. So if I can create this glass room and have an extra scrub, we can do much more than that in the same period of time that we do. So we're done the right eye. We'll switch to the left side. Troy is already ready, and the setup is already completed. Jordan moves into the glass room to set up the 2 tables for the fourth patient. So this way it's really quick. There's no downtime at all. I think that's about it. So let's go to back to the presentation. Okay, doesn't want to go to the next one. Give me a sec. So these are the take-home message. Okay, bilateral surgeries are a paradigm shift. It should be the standard, but there's some barriers that we need to do, and the hospital needs to know the know-how to do the bilateral surgeries, and believe in that bilateral surgery makes a difference. It's a significant advantage for everyone in the system, but it needs collaboration from everyone. And I think to encourage more bilateral surgery, I think Medicare has to change their pay structure to encourage surgeons to do bilateral surgery than delayed sequential. Thank you very much. So, any questions? I'm not
Thank
here.
you so much. Anybody have questions? Because I know I could talk about this for a while because of you quoted someone that I've actually worked with. So I'm gonna let everyone else have a chance first. 35, but you could do 40 what?
The number of patients per day?
Yeah.
So currently we do 32 cataracts a day in the hospital. And it's mostly bilateral, some singles, depend on the patient's needs. But I can think easily we can go to 45 cataracts a day if I'm allowed some flexibility to know how to do things in the hospital. So if I'm allowed to have this glass room and have an extra scrub. So it's a very small investment from the hospital side to do that. It's a very, very small investment if they just think how much difference they will make in the waiting list. Waiting lists will disappear essentially. And actually, cataract surgeries make money for the hospital. We're one of the rare specialties that actually make money for the hospital. So because of the QBP, so actually hospital is paid nicely for the cataract surgery.
So the 32 cataracts, you mean 32 lenses? How many humans are you talking about? Is it 32 humans or
no, 32 eyes, let's say 32 eyes.
And your percentage of singles, bilaterals in a day?
So it's mostly 95% of the days bilateral surgeries. Singles are usually either they've done this first eye already, or they have a previous refractive surgery, so I do them one eye at a time, or they choose to do one eye at a time. And usually, when they come back after the first eye, they tell me I should have done both eyes at the same time. And it's just it happens all the time. They tell me, okay, you're gonna come back later and tell me I wish I did both eyes at the same time, and they usually do.
Something that would be streamlined in pediatric care as well, pediatric cataract, or just
We don't in our hospital. We don't do any pediatrics at all. So anesthesia, I don't have anesthesia. Last time I have anesthesia in my room was about 3 years ago. But we don't have anesthesia. When our anesthetists, they don't do pediatrics at all.
monitoring of the patients? I'm thinking about the role of the nurse.
I'm not hearing you well. Can you bring microphone, or I can't hear you?
Yeah, come
Or
closer.
can you repeat?
Oh, so Sherry's asking how the patient is being monitored as far as vitals while they're in. Are the nurses monitoring it all? Because
Oh,
you just
yes.
said you haven't had anesthesia in the room for 3 years.
Yeah, yes, that's they monitored at the hospital. They're monitored by the anesthesia nurse. Yeah, at the center we don't do IV sedation. We do sublingual sedation, either by the Xanax or Ativan or MKO. So MKO is a mix of 3 sedatives that give me the same effect as the IV sedation without having an IV, because that's another thing that we do at the hospital with that I think should be changed, which is the IV sedation. We don't need to do IV sedation. For cataracts, sublingual sedation should do the trick. But they're monitored during the procedure to check the pressure. So we check it in day surgery and then check it at the beginning of the procedure. And in between the eyes, we get another check. And the end of the second eye, we do another check of blood pressure and monitor EKG, everything. Yeah.
So they're wearing a BP cuff and an ECG, 3-lead, and an O2 sat.
Yes, exactly. Yeah.
And when you talk about having an anesthetic nurse, are you talking about an RN AA that's with you, or an
Yes.
RN that just has clinical training?
No, a regular
An
RN. So it's not RA. No, it's a regular RN.
So not an anesthetic assistant, just
Yeah.
an RN.
Yeah.
Not
Again,
just- sorry.
our sedation mostly.
An RN that is specializing in that, yeah.
Yeah.
You
Our
add
sedation are mostly
anesthetic
light IV sedation. Pardon, I didn't hear that. Go ahead.
Oh, I asked if there were anesthetic assistants at Cornwall, and apparently there's one. So when you were showing the hospital, there was one nurse charting. Is that the nurse who's monitoring vitals as well? And there was some handwriting.
Let me show. We'll go back to that. I'll put that video back. Let's see. So we have the 3 nurses. So we have here, Brianna is doing the charting and circulating. This is Katrina. She's doing the anesthesia part, the monitoring. You can see the monitors connected to the patient here. And we have Bonnie. This is our scrub. Of course, they change from one week to the other, but this is the usual setup at the hospital.
The nurse that has the monitor with the anesthetic machine, are they doing digital charting for that patient's chart? Or
Oh,
is
yes,
it all
yeah.
happening on the left-hand side?
No, it's directly from the monitors into the Cerner. Yeah,
And
there's
the
no paper
papers,
chart. There's
so
no
the
paper
papers
chart
are-
from their side. Yeah.
but the papers being filled on the left are all your intraocular lenses and your paperwork for that?
Exactly. Yes. Yeah.
Do you have RPNs and RNs on this team, or is it all RPN? Curious.
So
All-
the scrub can be RPN or RN. The circulator can be RN. Sometime I'm not sure if the circulator can be RPN, but the anesthesia is RN.
I'm just
Go ahead.
curious about, are there other reasons, do you think, why other surgeons are not taking this up? Speak about the efficiency, and
Yeah.
certainly we see that in terms of, wait
So-
lists. So this seems obvious to me that, it's the option of choice.
It's an excellent question. I always ask them that question. I think a lot of it is financial. Okay, so if you're limited, for example, to 15 cataracts a day at the hospital, and you're going to do them bilateral, you get penalized by decreasing the pay. So I think if they decrease that kind of penalization and make it equal at least, so you get paid the same, I think these more surgeons will be inclined to take that. This is one factor. The second factor was the fear of bilateral complications. So if you're not sure about your complication rate, or you think your complication rate is a little bit high, you're probably going to be inclined to do one eye at a time. This is the second thing. Yeah. So it's mostly that kind of thing. You worry about the complications from the patient point of view, from the surgeon point of view, and the pay.
There's evidence to support, like you're saying, in relation to infection and efficiency.
Yeah, yeah, and the third thing that is what I'm trying to fix here also is the know-how. Usually, if the hospital is used to certain kind of routine and surgeons are used to a certain kind of routine, it's very hard for them to change. They don't change easy. You have to be really progressive to change what you do. So this is one of the factors that is surgeon dependent. So the more progressive surgeons, the more they do these kind of things. The more conservative the surgeon, the more they're going to stay with what they used to doing. They're not going to change too much. So, but the know-how, if the hospital and especially the nursing, if they know how it is done, and anybody is welcome to join us anytime if you want to come and visit us. And we have visitors from across Ontario that they come and visit us every once in a while to see how we do this. So anybody's welcome to go. So if the nursing know the know-how, the surgeon might be more inclined to do it more.
So you quoted Dr. Steve Arshinoff at one point, and I noticed that name because I worked with him for 6 years.
Okay, that's great. So you know how it's done then.
2001 to 2007. I wasn't exclusively in the cataract room, but
Yes.
I did all the services. He did many, many presentations, both in North America and off the continent, and was met with a lot of skepticism. So I was really curious to have seen the numbers from Spain and Finland where they were doing the bilaterals more often. So there was a culture definitely at the beginning of the 2000s that anyone who was doing immediate bilaterals was a bit of a risk taker for some of those concerns that you brought up. So it's good to see that it's starting to be accepted in more places. Yeah, I definitely was happy side. I'm doing many, many cataracts.
Yeah, I agree with you 100%. And actually, Steve helped me out when I started in 2009 by giving me the know-how. So I got his papers and I spoke with him. And actually, when I started to do bilaterals, first thing, the problem was my colleagues. So actually, my colleagues started to complain about me because the patients started to pressure them to do the same bilateral surgeries. So my colleagues started to complain to at that time as my boss in Cornwall to tell him, okay, get him to stop. So I contacted Steve and I got the literature and the scientific basis of doing it. So, and I sent it to my boss, and she sent it to my colleagues. So I said, okay, no, he's not going to stop. He's going to continue as long as it's working. It's not a problem. So I met a lot of resistance from my local ophthalmic community doing that. I'm still an outlier in this community doing the bilateral surgeries, and not a lot doing it. So it's still there, but everybody does what he wants to do as long as they know how to do it and do it safely. So I agree with you. It was a lot of resistance at the beginning, and Steve personally helped me with that to get started and supported me actually when they complained, because I told him, okay, well, Steve is supporting me, and he's a well known in the Islamic community, so backed out. So that's what happened.
Definitely been doing it for more than a decade by the time you started to do it in 2009. So we had the data and the statistics to come with them. We know that nothing changes without research.
Yes.
We didn't go this fast. We Humber River York Finch site before it was the huge Humber River, because that only started in 2015. I'm not even sure they're doing ophthalmology at the Big Humber River anymore. They kind of shoved everybody out into the smaller clinics.
They
Um,
did, yes. And
So-
actually, it's a good thing that they do that. I think eye care should be supplied in a small outside of the hospital center that's fully equipped for this. But we still need some hospital for really the pediatrics and really the bad cases that need to be done in general. So it's not good to cancel completely the in-hospital services for us for cataract surgeries. But I think uh, doing it outside the hospital in small centers is a good model for eye care. And I started the center is the Premium Vision. I started it about 10 years ago, actually. Because it made sense for me to have everything done in one spot, to have everything. I have all the same what I do and what kind of machines I get, what kind of lenses. So I had so this freedom give me a lot of chances to improve things. So one of them is light adjustable lenses. A lot of advanced premium lenses are done in the center because uh, I don't have to ask anybody about anything because as long as I feel it's safe and effective and it's good for the patients, I will do it.
So from the nursing point of view, I'll come back to you, Sherry. Humber at that time was staffed at 2.5, so you would just get relief. Dr. Arshinoff was probably doing 8 patients for 16 bilateral, like 16 eyes, bilaterals in a day. Cataract surgeons at that time who were doing singles were doing between 19 and 21 single people, and the turnover was nuts to try to turn over 21 times between the single eyes. What happened when you were in a multi-service hospital, you ended up with about 5 people that were comfortable doing cataracts. And then when those people were on vacation, and Susie, who'd been in ortho for the last year, was told she had to go do cataracts, Susie would be having heart palpitations because she didn't remember it had been too long, hadn't been in service, a new phaco machine, like whatever the multitude of reasoning in behind. So that's like, as you say, Dr. Youssef, it's great to have the clinics where you can have a dedicated staff that know what they're doing, and you can be staffed at 3 people right out of the gate, or 4, even some of the dancing there, it seemed like there was 4 people in the room. But then when you do the really sick people in the hospital, you end up with a base of nurses that haven't done one in 6 months or haven't done one in a year. So I appreciate the fact that you're not being handed instruments, because that was a challenge working with our cataract surgeons when I did it years ago, is trying to pass this to someone under a microscope and squirt the cornea so I can see what I'm doing, kind of tripping. It's good to see that you're quite self-sufficient that way. Any follow-up questions or comments on that?
Yeah, it's I hate when nurses pass me instruments. To be honest with you, Bonnie was away for a while and just came back to the hospital, and she started passing me nurse instruments, but I didn't want to say anything. I just kept getting, but after a few cases, I thought, okay, by the way, I don't want you to pass me instruments. Nothing against you, but really, I don't want. And I told her the reasons. I don't want somebody to be waiting, holding an instrument for me. I have enough arm length to reach the instrument anywhere on the table. So just put the table, just put it ready, and just leave. And I don't need anybody to squirt the cornea. I cover the cornea with Indecoat. It can last for about 15 minutes. So the surgery is typically 5 minutes. So for me, having a nurse waiting for me, it doesn't make any sense. So that's why we're able to save time by allowing the nurse to set up the rest of the table. I can start before she's finishing setup, and she can do the setup of the second table. So and injuries and instrument drops happens by handing instruments. Okay, so uh, I stabbed at the beginning when we were passing instruments. Of course, you pass a knife or something like that. Somebody is in the way, you end up stabbing them without knowing. So these kind of things you avoid completely by putting the instruments. We drop instruments by passing instruments. So for me, it's passing instruments is out of the question. So and really, I don't want anybody to pass me anything. I have enough. As long as you put it in my reach, I can actually reach it and have very long arms, which very handy in the OR.
Sherry, you had something.
I was just curious, do you have residents that come? And I'm thinking about just building capacity. So I wondered about residents and training as a way.
Okay,
to-
yeah. So Cornwall is not a teaching hospital. I would love to have residents because I want to teach them how they should do it. But we don't have we're not a teaching hospital, so we don't have residents. That's just myself and my colleague, and that's it.
I assume that was the case, but you know, I was just thinking about, yeah, how to build capacity in doing what you do.
I'm not hearing you very well. Can you say that again?
Sherry was mentioning how we're trying to pay the idea forward to build the capacity to be able to take this to more places. So we'll go back to the Toronto area and start whispering in every ophthalmologist's ear that we can find that someone's doing great work in Cornwall and maybe they should go on a road trip.
I think they should, and you have Steve there, and you have I think Kensington Eye Institute. I'm not sure if they do bilateral as routine, but all the private centers they offer this as a niche kind of service, a good service for the patients. So I think the public hospitals need to do that too, especially COVID. You know, COVID, we cut the waiting list significantly by being able to do the same number of eyes, but the least number of patients that way. So it's the way to go for public or private hospital. It should be. And anybody wants to get them to visit me, I'm ready to tell them how they know how and everything.
We'll keep that in mind. I can speak for Kensington from personal experience. 10 years ago, I was diagnosed with a choroidal melanoma, and after the radiation at the plaque brachytherapy at Princess Margaret, I've slowly but surely been getting all the radiation complications. So I've had a cataract done in the cancer eye at Kensington Eye Institute, and it was fascinating because the surgeon is from Sunnybrook, where I'm in the OR at Sunnybrook. Not his OR, but anyways, I'm a Sunnybrook employee. I was telling him, everybody talks about the beautiful lights. There's such beautiful lights in the colors. So as he was doing the surgery, I said, oh, you just split the cataract. I can see you took out that part of the lens. And I was describing to him every single step because I've passed instruments for about 400 of these, I figure, over my 6 years. And the resident didn't know who I was. And so after they wheeled me into the room, the resident's like, how did she know all that? And I actually knew the scrub nurse, and of course I knew my surgeon. So they're like, oh, it's because she's been an OR nurse for 15 years and she's done. So instead of someone just saying, oh, the beautiful colors, or you can see the viscoelastic going in and making little snakes. And it was fascinating. Dr. John Lloyd, who works at Sunnybrook, he found it fascinating as well because I could identify when I saw what I saw instead of just giving a description at the end of the surgery. So it was kind of fun. Yeah, Kensington worked really well.
Yeah, I agree with you. I have this is one of the methods I do what are called verbal anesthesia. So if a patient is stressed, I distract them completely by talking about the lights and how the lights look, the shapes of the lights and the colors and how the colors are different from one eye to the other. I just keep talking to them about this, and finally they're relaxed and they're done. So I use that kind of experience to put patient at ease and keep talking to them because patients want us to talk to them, want us to keep talking about anything. So I found that the lights and the colors are a perfect way to do that. I call it verbal anesthesia. And I have one of my YouTube videos actually. Patient is very descriptive to describe the colors she's seeing, like exactly what you're saying. But I recorded on with audio, so you can actually see it. And the people say, "Oh, I see it now with red color. Oh, I see orange and pink." And so it was a fascinating thing. So.
And I have been with Dr. Arshinoff where there has been a rupture in the capsule and we've lost the lens out the back and they need to go to a vitrectomy and we cancel the second eye and we send them away to make sure that first eye gets treated as best possible before we just carry on. So, you know, as with anything, there are moments where you can't always do both, but those were very, very rare.
That's a very important point, and I actually tell the patient that when I counsel them about bilateral surgery. I tell them if I have a problem with the first eye, I'm going to cancel that second eye, or postpone it, or talk to you about it. So it's that's what I tell them, and that's why I usually start with the easier eye. So that's why the arrangement I do with the right, left, left, right, right, left, left, right, it's not haphazard. So this arrangement is arranged so that I start with the easier eye. Some patients it doesn't make a difference, but some patients have a quite significant cataract in one eye more than the other, and these are the patients I start with the easier eye. So if I get a complication, get it second eye, I don't have to cancel the second eye, the first eye. Yeah, and I actually, if you look at the papers that the bilateral procedures, actually the complication rate is less than single procedures, and I think it has to do with selection bias. So the surgeons that do bilateral procedures already have less complication rate than the surgeons that do singles. You know what I mean? So that's why the complications in actually bilateral procedures is less than the single procedures.
I know my specialty is orthopedics, and the similarity is people that need surgery who are afraid of surgery, no matter what part of the body it comes from. If it's a bilateral thing, eventually they leave the first one like almost until it's too late, and they absolutely can't manage anymore. Like if they've left a knee for forever and ever and ever, they're back faster for the second knee because they know what the surgery looks like. They're not about to waste their quality of living for ages and ages. So being able to do both eyes at the same time can really, as you said in your presentation, it impacts their life so quickly within a day or two, driving 24 hours later, you know, and just being careful how heavy you lift for a couple of weeks. There is no recovery time. And so as long as it's done in a thoughtful manner, it really brings someone that has bilateral issues, it brings them such a huge difference the very next day.
And actually, even the lifting is not a restriction anymore. Lifting, bending over, I don't restrict this activity. I tell the patient, okay, immediately after you can stand upside down if you want to. You can bend over, lift heavy. It's not a problem at all, as long as you don't rub your eyes. The only thing that's going to open that wound is if you rub your eyes. If you rub your eyes, you open the wound, you lose the content, and you lose the eye. So bending over, lifting heavy activities, I don't restrict those activities anymore. It's just somebody asked me, oh, it's my gardening season, I want to do gardening. Okay, just wear protection and go gardening right away. There's no problem. Can I play golf? Yeah, you can play golf right away. I don't restrict any of the patient's activities except, of course, rubbing the eyes or swimming. So swimming because I don't want water get in the eye or they end up rubbing the eyes. So even that made it easier.
Yeah, Dr. Lloyd was just taking it easy on me, so I didn't have to go back to work the next day. Anybody else? It's been so very interesting. Thank you.
You're welcome. Thank you for inviting me. And if anyone wants help with this, I'm very passionate about bilateral surgery. I think it will solve a lot of our wait list problems and the cost of the healthcare and patients' convenience and fears. I believe in this thing. So if somebody needs to set up or start or something like that, please contact me and I'm very ready to help with anything I can.
Thank you very much. Jordan's going to give you a little thank you note, and we have a little thank you plaque that appreciates your time that you took today. If you want to hang it up in the office, we appreciate it. And we really very thank you very much for coming.
I wish I was there in person, but I have another conference in Montreal. So it's a retina conference, so I have to be there.
That's okay. We understand. And the teams worked very well. So thank you so much.
See, the teams is great, but I feel there's no personal touch. So I haven't met you in person, which is stuff that we got used with in COVID a little bit.
Well, if we end up back in Cornwall and you can come speak to us in person, you're definitely invited back.
I will do that, and I want you to come to OR one day. So feel free to come
Okay.
in.
Thank you so much for your time and have a
Thank you
wonderful
much.
evening and enjoy your
Thank you.
conference in Montreal.
Thank you much.
Thank
Thank
you.
you. Appreciate it. Thank you, Jordan. Thank you. Have a good evening. Bye-bye.
Well, now, because I have eye issues, that was interesting for me, but how about everybody else?